Now let me take you on a different tangent. This patient, because you did a CT, you have a subarachnoid hemorrhage evidence there, and therefore you did go with the DSA. Let me put it on the other side. Suppose you had a patient who had a headache, and you considered an aneurysm as a possibility, but
Yes.
then you find that this particular patient had a normal CT when you do it.
Yes.
Then how do you think you will proceed? Will you still think it's subarachnoid hemorrhage?
Yes, we can still investigate. So we can, if we were still thinking of subarachnoid hemorrhage, we can, and if the patient is having any neurological deficit, we can go for a lumbar puncture and to look for any xanthochromia. Sir. So if the patient is having any xanthochromia on that, we can go for again a CT angiography, DSA, and then determine any presence of aneurysm.
Can you explain this in greater detail?
Yes, sir. So if the patient presents with a headache, severe onset, sudden onset headache, and the patient presents less than 6 hours, we can straight away go ahead for CT. And if it shows a subarachnoid hemorrhage, we can treat that accordingly. If the patient is more than 6 hours and with or without any neurological deficit, and we did CT, but there is no evidence of subarachnoid hemorrhage, we can go ahead with the lumbar puncture to look for any xanthochromia that shows the presence of blood. So if the if patient is positive for xanthochromia, then we can still go ahead with the CT angiography or and DSA to look for the aneurysms.
How will you differentiate from a lumbar puncture between a subarachnoid hemorrhage and a traumatic tap? What will happen if you have a traumatic tap? And what will happen when you have a subarachnoid hemorrhage? When you have a traumatic tap and you serially collect, will do you think the intensity of the blood in each of the fluids will go down? It would, no? In a patient with subarachnoid hemorrhage, serially, it will all remain the same, right? So that's how you would differentiate between subarachnoid hemorrhage versus a traumatic tap. Okay, so this particular patient presented with the seizures. This particular patient presented with the seizures. Okay, this patient presented with seizures. So your initial diagnosis was whether it was a seizure that was due to any other cause. So you did a CT, and the CT did rule out ischemic stroke or a hemorrhagic stroke, and then you were able to make the diagnosis of subarachnoid hemorrhage. This was not considered very common in this particular patient because this patient did not have the classical presentation that you'll usually account with, namely thunderclap headache or onset of headache during exertion, no neck stiffness that this patient reported. But nevertheless, in any patient who's got uh, loss of consciousness and above 40 years, you would consider subarachnoid in the differential, which is what is there. And of course, this patient also highlighted the fact that in a patient with subarachnoid hemorrhage, you may have a normal CT very rarely. In that instance, if you're still thinking that it is subarachnoid hemorrhage, you would go ahead and do a guarded lumbar puncture. And when you do a guarded lumbar puncture and you see blood, the question arises whether this is a traumatic tap or a subarachnoid hemorrhage. Here you can understand that when you collect the sample serially in a traumatic tap, the intensity of blood will come down slowly. But in a patient with aneurysmal subarachnoid hemorrhage, it will continue to be bloody in all the serial samples. Yes, Dr. Sindhu, please continue.
Yes, sir. So we can look for xanthochromia, and if it is positive, we can go ahead with the CT angio to look for the aneurysms. Tell me, sir.
Please tell me. Please tell me. In this patient, based on now you have a diagnosis of subarachnoid hemorrhage based on the CT. So
Yes.
here, specifically when you talk about subarachnoid hemorrhage, how would you like to approach your patient? Because you did talk about a specific management. You said that you'll have a general management where we'll address the A, B, C, D, and then
Yes.
specifically you will address the problem. Of course, you did treat the seizure with a loading dose of levetiracetam. And you did think that this patient had no non-convulsive status because her GCS had returned to normal. You had a CT done,
Yes.
and the CT suggested aneurysmal subarachnoid hemorrhage. So when you are talking about aneurysmal subarachnoid hemorrhage, how would you really approach this particular patient from here on?
Initially, we can actually categorize the patients based on the severity of the SAH. There are a few classifications here.
Okay.
So based on the patient clinical examination, and it can be based on the radiological examination of the patient. So based on clinical examination, to predict the mortality of the patients, we can have two classifications: Hunt and Hess and World Federation for Neurological Societies. So there are five grades in both the grading systems. So first three grades will carry a good prognosis, and we can go for the immediate treatment. The fourth and fifth grade, they carry very poor prognosis, carrying even 80 to 90% mortality in those patients. So first grade, sorry, sir.
Okay. Which grade do you use, the Hunt and Hess or the WFNS?
We usually use Hunt and Hess. Sir.
Okay.
And
But yeah, you could use,
both the
but I
clinical
think
GCS.
the
Yes.
WFNS is now more universally accepted.
More, yes.
So can you tell us a bit about both these gradings?
Yes, sir. So first grade patient will usually be asymptomatic, or they can present with very minute headache, and the GCS will be 15 by 15 without any neurological deficit. So the second grade, they'll have a GCS of 13 to 14, and without any neurological deficit, and they can have moderate to severe headache and some nuchal rigidity. Third grade, again, GCS of 13 to 14, but they'll have some focal neurological deficit, and they can be a bit confused. Uh, and fourth grade is GCS anywhere from 7 to 12, with or without any neurological deficit, but the patient will have severe severe hemiparesis, and the patient can present with stupor. Uh, Grade 5, anything less than GCS less than or equal to 6, and the patient will have extensive posturing, and patient will be in coma, and they carry a huge mortality and morbidity.
Okay. Now, this patient of yours, which grading
Yes.
system will you use in the Hunt and Hess and
Yes.
WFNS? And before that, I just thought very well done, but I'm just going to reiterate the Hunt and Hess and WFNS separately for the benefit of whoever is attending. In Hunt and
Yes.
Hess, which was the previous one, if you are asymptomatic or if you have just mild headache, it's grade 1. If you have more headache and you have only cranial nerve palsies, it's grade 2. Anyone who's got a neurological deficit, it becomes either 3, 4, and 5, depending on the severity of the neurological deficit. In addition, if you have confusion on lethargy, it's grade 3. If you are more drowsy, it's grade 4. And if you are in coma, it's grade 5. Likewise, because the Hunt and Hess grading can lead to ambiguity, and therefore, because GCS is something that is more objective, the WFNS is now used. So if you have a GCS of full without any focal deficit, without any hemiparesis, it is grade 1. If you have a mild drop in GCS, that is 13 to 14, depending on whether you have hemiparesis or not having hemiparesis, you will have grade 2 or grade 3. If you have a GCS between 7 to 12, that's grade 4. And if you have a GCS between 6 to 3, it's grade 5. So based on this is the WFNS, and WFNS is more commonly used nowadays. Now, your patient, which grading system uh, does this patient fall into?
This patient is have grade 1, sir. So if we use Hunt and Hess, initially it could have been grade 2, because she presented with confusion, but after that she
Grade
rapidly
3.
improves the GCS 15 by 15. So grade 1 in both the systems.
Okay, this is usually when this particular patient presents to you, that's when you grade them. So
Yes.
this was so that's where she is. So based on that, what is the mortality of this particular patient? Estimated mortality
Yes,
based on that?
estimated mortality is 30%, sir.